the Bald Oncologist podcast series, featuring Dr. Malwinder.
Hello everyone, welcome to the Bald Oncologist podcast series. In our studio today, we have Dr. Navin. He's a consultant colorectal surgeon. So hi Dr. Navin, welcome to the show.
Hi Dr. Malwinder, how are you?
Fine, thank you.
Thank you for having me.
Okay. Mr. Navin, can I just ask something? What is our national screening program in Malaysia to detect early colorectal cancer?
So at the moment, colorectal screening is just an opportunistic screening program whereby patients who present with symptoms or who would like screening, then they would come and approach us for tests. Okay. And some of the tests that we do are FOBT tests and our fecal immunochemical test.
What one of those tests actually?
These are actually quite simple tests. Something like your COVID test, you take and you just mix a little bit of stools in the specimen and they'll test for the presence of blood in the samples.
So this can be done as in their home or just come to the hospital to do it?
Usually the clinics will prescribe the screening test to you. You can do it at home and then you bring the sample and present it back to the doctors.
Also, the doctor have to put the test to see whether it's positive or negative.
Yes, they will have to look at the specimen, the results actually.
Okay. Yeah. Okay. And then if it's positive, what's the next step?
So if it's positive, these patients should get a colonoscopy done, and this would pick up like early tumors or polyps, which are very helpful to prevent cancers in the future.
Okay, so is there like a way that you skip on this? Like some patients just come and ask me, I want to do a colonoscope straight. Is it okay to just straight away jump to a colonoscope?
Actually, it's perfectly fine for that to jump straight away for a colonoscope, because if you're presenting with overt symptoms, just go ahead, get a colonoscope done as soon as possible.
So how often do you do a scope for screening?
So if these patients are at the low risk category, you can just do a screening every 3 to 5 years. Okay. Yeah, but if you're in a higher risk or moderate risk category, then you should get it more frequently done. And if you especially have genetically proven cancers, then even more frequent.
Okay, so the FOBT and the fecal test and all which you're mentioning, how often you do that? Is it every year or same thing like 3 years?
See, every 3 to 5 years, you can just do a test. Yeah.
Okay. So some of the patients which I've seen, right, after diagnosed with colon cancer, when they go for surgery and all, some patients might need stomach. And then subsequently, after a certain period of time, they can reverse the stomach. So I always get patients asking me, why do patients need to go through 2 procedures? Can't they just resect the tumor and suture together, rather than doing a stoma and then reversing after a while?
Okay, stomas are done for these patients who present in a very obstructed or emergency state, whereby joining back the bowels would cause potential leak. We do not want a leak because it can cause a lot of morbidity and harm the patients.
What you mean the bowels are not healthy because there's cancer cells there?
Exactly. The bowels are not healthy because they are edematous and they are not suitable for a joint state at that point. That is for in an emergency setting. But if a patient actually has a very low rectal tumor, then these group of patients also would require a covering stoma just for temporary measure. And those with a very low rectal tumor or anal tumors, they would actually require a permanent stoma.
Okay. And this stoma, normally once when it's done, how long do you have to wait before you can reverse it back again?
It's quite variable. It can be as early as 3 weeks, and it can be as late as 3 to 6 months after the chemotherapy. Yeah, if they require chemo.
Okay. So it's not like 100% anyone with a colorectal cancer would end up with a stoma?
Absolutely not.
What is the percentage like for patients who actually end up with a stoma?
It's about 15 to 20% chance of them requiring a stoma, especially if it's in the very low left side of the tumor, left side of the colon.
Okay.
Yeah.
Okay, so any of your patients which you have any experience, or how long do you think a colorectal cancer patient can survive actually?
Okay, there's 4 main stages, and obviously in the stage 1, these are the best prognosis, and these patients can live up to more than 5 years. 90% of them can live for more than 5 years for stage 1. For stage 2, it drops to about 75%. Stage 3 drops to about 60%, and obviously stage 4 is a bit lower at 40%. This is with good chemotherapy, good follow-ups, and these can increase the patient's survival.
So what are the treatment options which a patient normally have to go through? Is it like always your surgery and then you're done with it? Or like I see some patients always do like some chemo before or some chemo after, some they put in some radiotherapy. So how do all of these actually tie to the picture?
So basically, if it's a lower rectal tumor or a mid-rectal tumor, this patient would require chemotherapy and radiotherapy before the surgery, as this would improve the patient's survival and reduce the local recurrence.
It also shrinks the tumor, right?
Exactly. Shrinks the tumor, prevents the tumor from coming back again. So it's quite important for this group of patients to get chemotherapy and radiotherapy before the surgery. And even after surgery, some of them might require chemotherapy after that. And these are for rectal tumors. But for colonic tumors, any tumors higher than the rectum, then most of them would just require chemotherapy after the surgery.
Okay, so surgery first, then followed by chemo.
Yeah.
So for an example, a stage 4 patient, what's the longest survival of stage 4 patients you had?
Okay, now stage 4 cancer, it's a bit debatable because those with very little tumor, oligometastasis they call it, they can survive longer if they are suitable for surgery. So sometimes you can actually remove the tumor and also the areas where that's spread.
Which is spread, yes.
As in like in the liver, lungs, if it's a very small tumor in the lungs or the liver, it's quite, and if it's resectable, they can actually survive as high as a stage 3 patient for up to 60%. That kind of survival for more than 5 years.
Yeah, I remember those days during my teaching that a stage 4 cancer patient normally don't survive very long. But with all our newer therapies and all, colorectal cancer is one of a stage 4 patients where you can actually aim for cure state, provided you can actually resect the tumor and also the metastasis.
Yeah, right. With a good targeted therapy and obviously a good systemic therapy after that is important as well.
So for me as an oncologist, normally what I do when I see a patient is actually I need a biopsy. Ultimately, every patient is a biopsy because from the biopsy specimen, it's very, very specific to that patient. So we talk about personalized medicines nowadays. No more like cancer patient stage 4, everyone get treated the same or do chemo and then after that just wait for the cancer to grow. So nowadays we have like targeted therapy, immunotherapy. Even our chemotherapy has already evolved over many, many generations. So we have newer drugs and all, which are minimal toxicity. Okay. But the important thing is personalized medicine. We need a biopsy, we need to send to the lab to see what mutations they have. If they have certain mutations like KRAS, NRAS, BRAF, HER2, MSI, so there are many treatments available for all of these mutations. And so with all these mutations, when we have something specific, survival gets longer. So I have colorectal cancer patients stage 4 who actually survive up to 10 years also, but they go through many, many rounds of treatments. And nowadays we're trying to make cancer as chronic as possible, something like diabetes. You just carry on taking tablets or medicine, and you just live a long life, provided you don't have a lot of side effects. And we try to improve your quality of life.
Yep.
Ultimately, that's what we want, right?
That's right.
Yeah. Okay. So anything you want to say to our audience about colorectal cancer, since it's March is Colorectal Awareness Month?
So basically, we have symptoms, early symptoms, come early, get it treated. Don't assume it's hemorrhoids or, something very vague. Just get it screened or do a colonoscopy as soon as possible. And every patient is different. They're tailored according to their disease itself. And we all work as a team, so we should manage all these patients as a whole. Yeah.
Thank you so much. Thank you for the advice.
Thank you.
Thank you for being in the show.
Thank you. Thank you for inviting me.
Thank you.
The Bald Oncologist podcast series